If you are organizing a monumental life event, like a wedding or maybe a 10-year anniversary or even some elaborate international honeymoon, you already know that success isn't just dictated by your budget.
Right, it's all about the timeline.
Exactly. It's dictated by the timeline. You have this meticulous, like almost militaristic spreadsheet going on. The venue needs a 12-month lead time. The dress alterations need 6 months.
Oh yeah, it's a massive countdown.
Right. And if you're factoring in aesthetic prep, you know that something like a neurotoxin injection needs to happen maybe 4 weeks out, just so the chemical paralysis peaks right as you walk down the aisle.
Yeah, that's standard for Botox and things like that.
Exactly. But if you try to apply that same standard aesthetic timeline to optimizing your biological intimate wellness, you are going to miscalculate entirely. So, welcome to another custom-tailored deep dive, where today we're looking at the exact biological protocols and highly specific timelines required if you want an O-shot booster session to hit its absolute peak for a major life event.
Yeah, and to map out a timeline that relies on actual tissue regeneration rather than instant chemical fixes, we are synthesizing a really specific stack of sources for you today.
Which we need because this gets complicated.
It does. So we're pulling clinical guidelines from practices like Berman Women's Wellness and Optimal Medical Group, and then cross-referencing those with bridal aesthetic timelines from publications like Premier Bride.
Right.
And we're grounding the entire protocol in hard data from a comprehensive PMC academic study that reviewed 235 female sexual health programs across the U.S.
Which is a huge data set. So the mission for this deep dive is really to unpack the specific cellular mechanisms of this treatment. Because honestly, you cannot understand the timeline until you understand the biology.
Absolutely. The biology dictates everything here.
Right. So we'll reverse engineer the precise countdown for a pre-event booster protocol, and then we have to break down the provider landscape. Because when you look at the academic data regarding who is legally allowed to administer this shot,
Oh, that part is wild.
it really is. It explains why you have to be incredibly discerning about where you book your consultation.
Yeah, the disparity between who offers this in a private setting versus an academic setting is, well, it's arguably the most critical piece of data for anyone considering the procedure.
For sure. But before we can get to the provider data or even the calendar month, we have to look at the hematology.
Right, the blood work.
Yeah. Because the O-shot, which is based entirely on platelet-rich plasma or PRP, it's often categorized alongside cosmetic fillers. But functionally, they have nothing in common.
No, not at all. You aren't injecting a synthetic gel to just, occupy space.
Right. We're talking about autologous therapy, which means using your own biological material.
Exactly. So rather than opening a prepackaged syringe, the provider is actually doing a blood draw from your arm.
Okay, let's unpack this. Because I imagine the effectiveness of the entire timeline depends on the physics of what happens next in the centrifuge, right?
Yeah, the centrifuge is where the actual isolation happens. They take that vial of your blood and spin it at just thousands of revolutions per minute.
Just separating everything out.
Right. This high-speed rotation uses centrifugal force to separate the blood components based on their density. So the heavy red blood cells, they sink to the bottom. The cell-poor plasma rises to the top.
And what's left in the middle?
Suspended right in the middle is what's called the buffy coat. And that thin layer contains highly, highly concentrated platelets.
Okay, but just isolating the platelets doesn't magically trigger regeneration, right? I mean, platelets circulate in our blood all day long without suddenly growing new tissue.
Exactly. Yeah, they're just circulating. There has to be a chemical catalyst right before the injection.
And that's the calcium chloride.
You got it. In a normal bodily function, say you cut your finger, the exposed tissue releases signals that tell those circulating platelets to break open and initiate clotting and healing.
Okay, that makes sense.
But because the provider is injecting this PRP into healthy, uninjured tissue in the anterior vaginal wall and the clitoris, they have to artificially mimic tissue damage.
Ah, so they're tricking the body.
What's fascinating here is that by mixing the concentrated platelets with calcium chloride right before the injection, it forces the alpha granules inside those platelets to degranulate.
Which essentially tricks the platelets into thinking a massive injury has occurred, prompting them to just dump their entire payload of growth factors into the surrounding tissue.
Exactly. That is the biological alarm bell. Once injected, that activated serum floods the local area with vascular endothelial growth factor and platelet-derived growth factor.
Wow.
Yeah, and those proteins bind to the receptors of the local unipotent stem cells.
Unipotent meaning they have a single committed destiny, right? Like they aren't those embryonic stem cells that can turn into a heart or a lung. These are local adult stem cells pre-programmed to only become local epithelial, vascular, or nerve tissue.
Right, exactly. They're basically just sitting dormant in the tissue. The growth factors wake them up and force them into rapid proliferation.
So they multiply.
Yeah, and over the subsequent weeks, those unipotent stem cells synthesize brand new collagen matrices, generate new nerve endings, and most importantly, they initiate angiogenesis.
Which is the creation of entirely new blood vessels.
Exactly.
So this isn't like pumping up a tire with air for an instant fix. It's more like planting seeds in a garden and waiting for the roots to take hold. But I have to ask, is this just an aesthetic fad, or is there functional healing happening here?
Oh, it's absolutely functional tissue regeneration. And looking at the clinical outcomes and the sources, the functional result of this upgraded infrastructure isn't just about heightened sexual sensitivity or increased natural lubrication. Those are primary drivers for a lot of people.
Right.
It's also frequently utilized for stress urinary incontinence. By thickening and vascularizing that suburethral tissue, it provides stronger structural support to the urethra.
So it's addressing the physical root cause of the leakage rather than just like managing the symptom?
Precisely. Which brings us to the reality of the timeline. Because cellular turnover, angiogenesis, and nerve regeneration, they operate on a biological clock, not your social calendar.
Right. So if someone treats this like a Botox appointment and books their initial consultation a month before their honeymoon, the cellular math simply doesn't add up.
It doesn't. You'd be totally missing the window.
Let's walk through the actual event protocol. According to the clinical guidelines and bridal timelines from sources like Dose Aesthetics and Premier Bride, Wisconsin, the initial runway requires significant foresight.
Yeah, the consensus dictates that the initial consultation and your first O shot must be executed 3 to 6 months prior to the event.
Wow, up to half a year out.
Yeah, because when you introduce activated PRP into the tissue, angiogenesis begins within days, but the complete maturation of those new blood vessels and the integration of new nerve tissue, it's a slow cascade.
So it takes a while to peak.
Exactly. The physiological changes, like the peak of that new sensitivity and structural support, generally do not fully manifest until that 3-month mark.
So month 1 and month 2 are basically active construction zones. The scaffolding is going up, but the building isn't finished.
That's a great way to look at it, yeah.
If you get the shot 2 weeks before you leave for your anniversary trip, your body is still in the middle of synthesizing early-stage collagen. You wouldn't experience the functional payoff when you actually want it.
And if you're trying to maximize the outcome for a specific date, just getting one shot 3 months out isn't even the complete protocol.
Here's where it gets really interesting. Can't someone just get this a week before their honeymoon? I mean, why do we need a booster?
Well, you can't do it a week before because, again, it requires cellular turnover, unlike Botox, which just paralyzes muscles quickly. The clinical recommendation for peak event results actually requires a compounding booster.
Okay, and the sources outline a very specific window for this second session, right? Between 8 and 12 weeks after the initial injection. I'm looking at the biological timeline we just established, and that 8 to 12 week mark lands exactly as the first round of angiogenesis is reaching its maturity. So you aren't just topping off the treatment, you are intentionally striking the tissue while it has maximum blood flow and cellular activity.
Exactly. It's a compounding multiplier effect. If you introduce a second massive dose of activated growth factors into tissue that is already hypervascularized from the first shot, the unipotent stem cells are far more responsive.
That makes total sense.
Yeah, you're no longer trying to regenerate dormant, atrophied tissue. You're taking newly optimized tissue and pushing it to a heightened biological baseline.
Wow.
And for patients dealing with more severe starting symptoms, like significant menopausal vaginal atrophy, that compounding booster is the critical difference between just a marginal improvement and a complete functional restoration ahead of their event.
Now, there is a specific biological caveat in the sources that disrupts this timeline, and it concerns postpartum patients.
Yes, this is really important.
If the major event is a delayed honeymoon or a vow renewal after a pregnancy, the clinical guidelines demand a delay. They recommend waiting 9 to 12 months postpartum, or at least 6 to 8 weeks post-breastfeeding.
You have to consider the systemic endocrine environment here. Postpartum, a woman's body is just saturated with fluctuating hormones. Relaxin levels are shifting, and if she's breastfeeding, estrogen levels are suppressed.
which naturally thins vaginal tissue. Right.
Exactly. Attempting to force localized tissue regeneration in an environment where the systemic hormones are actively working against tissue plumping and vascularization is just highly inefficient.
You're fighting an uphill battle.
Right. You have to wait for the endocrine system to stabilize so the unipotent stem cells have a hospitable environment to replicate.
Okay, so assuming the endocrine environment is stable, the patient has mapped out their 6-month runway, and they've secured their booster appointment right in that critical 8 to 12-week window. This brings us to the immediate taper period.
It's a countdown phase.
Yes, the days surrounding the booster shot require strict behavioral modifications. Let's look at the pre-booster protocols. Patients are instructed to aggressively hydrate in the days leading up to the draw. If we are harvesting plasma, I imagine blood viscosity is the primary concern here.
It is, yeah.
Mm.
It's entirely about the hematocrit and plasma volume. If a patient arrives dehydrated, their blood is more viscous, it's thicker.
Right.
When the centrifuge attempts to separate the components, a lower volume of plasma is yielded, and the concentration of platelets within the buffy coat can actually be compromised.
So hydration gives you more material to work with.
Exactly. Aggressive hydration ensures a robust plasma yield, giving the provider the highest possible volume of that liquid gold to activate.
They are also instructed to cease all NSAI use, so no ibuprofen, no naproxen at least a week prior. And post-booster, they enter what clinics refer to as the 48-hour rule.
Yes, a 48-hour rule.
The obvious restriction is no internal intercourse or tampon use to allow the injection sites to seal. But the restriction that stands out across providers like BD Aesthetic and Nor Health is the absolute prohibition of heat exposure.
No heat, period.
No saunas, no hot yoga, no jacuzzis for 48 to 72 hours. If a patient hits the hotel hot tub immediately after their booster, they are effectively sabotaging the mechanism of action. It's like tapering for a marathon. You've done all the hard work months in advance, but if you sit in a hot tub the day before the race, you ruin the whole thing.
And understand why, you have to look at how heat and NSAIDs interact with the inflammatory cascade.
Okay, explain that.
Well, the entire point of injecting calcium chloride-activated PRP is to provoke an acute, localized inflammatory response. Acute inflammation is actually the necessary first step of tissue repair.
Right, you want the inflammation.
Exactly. It signals the macrophages to clear debris and calls the stem cells to the site.
So if a patient takes an NSAID to manage the mild discomfort of the injection, they are chemically inhibiting the cyclooxygenase enzymes that produce prostaglandins. They are shutting down the exact inflammatory alarm they just paid to trigger,
And extreme heat exposure does something equally disruptive, but through vasodilation.
expanding the blood vessels.
Right. When you sit in a sauna or a hot tub, your core temperature rises and your body induces systemic vasodilation, widening your blood vessels everywhere just to release heat.
Which sounds bad if you just injected something locally.
It is. If you systemically dilate the vascular system right after receiving a highly localized concentration of growth factors, you risk increasing the systemic blood flow to the point where it diffuses or carries those localized proteins away from the target receptors.
Before they can even fully bind and initiate the unipotent stem cell proliferation, you are diluting the concentrated payload by flushing the area with excess heat-induced blood flow.
Exactly. It washes it away, basically.
Wow. It requires immense discipline. You have to endure the localized inflammation and avoid all your usual recovery mechanisms like anti-inflammatories or heat therapy just to protect the biological investment.
Yep.
And if a patient successfully navigates this entire timeline, avoiding the pitfalls, the clinical consensus across the sources suggests the functional results persist for 12 to 18 months, with some outliers maintaining sensitivity for up to 2 years before requiring an annual maintenance booster.
But preserving that delicate cellular response doesn't just depend on the patient staying out of a hot tub.
No.
It depends entirely on the person holding the needle, formulating the PRP, and administering the injection.
Which forces us to look at the provider data from the PMC academic study, because this is where the logistics of planning this treatment get incredibly murky.
Yeah, this data is wild.
The study analyzed 235 female sexual medicine programs in the U.S., the first major data point. Only 17% of these clinics were housed in academic or university settings. The vast majority operate as private practices or aesthetic med spas.
And the disparity becomes even more pronounced when you look at the specific treatments offered. Of the private, non-academic clinics reviewed, 47% offered PRP injections for female sexual health.
Okay, almost half.
Right. But when the researchers looked at the academic clinics, exactly 0% offered it.
So what does this all mean? If you're looking at a 47% adoption rate in the private sector and a literal 0% adoption rate in the academic sector, it naturally begs the question of legitimacy. Like, why won't major university medical systems touch this if the regenerative biology is as sound as the clinical protocols suggest? Is it just a med spa cash grab?
This raises an important question, and it really comes down to regulatory classification and the rigid structure of traditional medical hierarchies.
Okay.
PRP for female sexual dysfunction is currently classified as an investigational therapy because the treatment uses the patient's own autologous tissue, their own blood, and is minimally manipulated before being injected back into the same patient in a single procedure. It often falls under a totally different regulatory framework than traditional pharmaceuticals.
So it bypasses the traditional FDA approval pathway.
Exactly. If a pharmaceutical company develops a new daily pill for low libido, they have to run it through phase 1, 2, and 3 double-blind, placebo-controlled clinical trials to prove efficacy and safety before it hits the market.
Which costs millions.
Hundreds of millions. But because you can't patent a patient's own blood, there isn't a massive corporate entity funding $100 million trials for PRP.
Ah. And because academic institutions rely strictly on standard of care protocols established by those massive peer-reviewed double-blind trials, they are structurally slow to adopt autologous regenerative therapies.
Right. They require a burden of traditional clinical proof that the PRP industry just isn't incentivized to fund.
That makes a lot of sense.
Conversely, private aesthetic and wellness spaces operate with much more agility. They're already utilizing PRP for facial regeneration or hair restoration, so applying the same regenerative principles to intimate tissue is just a natural lateral expansion of their services.
But that lateral expansion in the private sector creates a massive regulatory loophole regarding who is allowed to perform the procedure.
Absolutely.
The PMC study found that while OB-GYNs make up about 40% of the providers in this space, the rest of the field is a highly fragmented mix of specialties. They documented emergency medicine physicians, anesthesiologists, and even chiropractors administering female sexual health treatments in these private aesthetic clinics.
Yeah, the inclusion of chiropractors administering a highly specialized, localized injection into the anterior vaginal wall. It just highlights a critical vulnerability in the current medical landscape.
I mean, a chiropractor's scope of practice is neuromusculoskeletal. The fact that a legal framework allows a practitioner trained in spinal adjustment to legally purchase a centrifuge and administer intimate regenerative injections is staggering.
It is.
It places the entire burden of vetting the provider squarely on you, the patient.
This is exactly why the sources are adamant about certification. The O-shot is not just a generic term for vaginal PRP. It is a trademarked, patented protocol.
That's a huge distinction.
It is. The Cellular Medicine Association is the governing body that holds that trademark, and they require advanced, specific training to even use the name. If a practitioner is not explicitly certified by the CMA, they have not undergone the standardized training for the precise anatomical injection sites or the correct calcium chloride activation ratios.
And if the activation ratio is wrong, the alpha granules don't degranulate, the stem cells never get the signal, and you've effectively just injected inactive plasma for absolutely no reason.
Exactly. Or worse, if they lack the anatomical expertise, they risk nerve damage in an incredibly sensitive area.
Yikes.
Yeah, you cannot rely on the ambiance of a high-end med spa to indicate medical competence. You have to demand to see their specific Cellular Medicine Association certification.
The protocol leaves zero room for error. The biological mechanisms are sound, but they are entirely dependent on clinical precision.
Completely.
So to synthesize the entire countdown, if you are looking at your calendar, planning for a major life event, you must start the process 3 to 6 months out.
Right.
You schedule the compounding booster precisely at the 8 to 12-week mark to capitalize on the initial wave of angiogenesis. You aggressively hydrate. You eliminate NSAIDs to ensure your inflammatory cascade is fully primed.
Yep.
And you avoid all systemic vasodilation, so no heat, no saunas for 48 hours post-injection. And above all, you interrogate the credentials of your provider to ensure they are CMA certified and not just capitalizing on an investigational loophole.
It is a demanding timeline.
Yeah.
But there is a final concept embedded in these sources, particularly from clinics like Prosper and Little Elm, that kind of reframes the entire purpose of this treatment.
Right. They suggest that relying on the injection alone is short-sighted.
You do. These progressive clinics strongly advocate for combining the O-shot with 2 auxiliary modalities, pelvic floor physical therapy and comprehensive hormone optimization.
Oh, wow.
Yeah. The physical therapy provides neuromuscular re-education, so it's training the newly vascularized tissue to contract and release properly, while the hormone balancing ensures the systemic endocrine environment is actually supporting the local tissue regeneration.
It shifts the paradigm completely. It forces you to stop looking at the O-shot as a standalone aesthetic like Magic Bullet and start looking at it as a biological catalyst within a larger system.
Exactly.
It treats intimate wellness the way a sports medicine physician treats athletic performance. You wouldn't inject PRP into a torn rotator cuff and just hope for the best. You would utilize the injection to accelerate cellular healing, and then you'd spend months in physical therapy retraining the joint, all while ensuring the athlete's nutrition and hormones supported recovery.
It's the full integration of regenerative medicine, neuromuscular conditioning, and endocrinology. It suggests that the future of female intimate health isn't going to look like traditional compartmentalized gynecology.
Right.
It's going to be holistic, multidisciplinary, and honestly, heavily reliant on patient discipline.
Which means mapping out the timeline for a major life event becomes even more complex, but infinitely more rewarding. You know, you can easily outsource the catering, the venue, and the floral arrangements to a planner. But optimizing your own biological infrastructure requires a deep understanding of your own cellular mechanisms, a respect for the pace of angiogenesis, and the willingness to actively participate in your own regenerative healing. So thank you for joining us on this deep dive. Stay curious, demand the data behind the protocols, and we will see you next time.